Parkinson's disease. This is a systematic review that is held in Isfahan University of Medical Science in Isfahan, Iran. And I have to thank my colleagues, Dr. Paul, Dr. Salehi Nejad, and Professor Nietzsche from Germany. As you know, Parkinson's disease is a major neurodegenerative disease in the world. That we know this disease with some problems like bradykinesia, dystonia, tremor, and postural balance disorders. But we have to focus a problem that we term it gait disturbance. As you know, gait disturbance is a very major problem in patients with Parkinson's disease, and they have some problem in risk of falling, and also these problems has a negative impact on their quality of life. The imaging studies show that in Parkinson's disease, we have some degeneration in dopaminergic neurons in substantia nigra, and also some functional changes in area like supplementary motor area and in primary motor cortex, and also dorsolateral prefrontal cortex. So it seems that if we have find some treatments, some approaches to improve the function of the brain, we can have some positive effect on gait and on postural problem in patients with Parkinson's disease. There is a non-invasive brain stimulation technique. We call it transcranial direct current stimulation. This is a weak current stimulation that we apply on the scalp using anode or cathode electrode. And we believe that anode electrode can facilitate the brain activity, and cathode electrode will depress the brain activity in the targeted area. And if we use it for a long time, if we use it in combination with therapeutic exercise, we can see some neuroplastic change in the brain activity. So we conducted this systematic review to see the effect of TDCS, I mean transcranial direct current stimulation, on gait in patients with Parkinson's disease. As you see, finally, we included 18 studies in our review. As a result, as the main result of this review, we found 10 studies that applied TDCS on primary motor cortex. We call it M1. The target area in most of them was 1 to 2 centimeters anterior to vertex. It seems that when we applied electrode anterior to vertex, in addition to M1 primary motor cortex, we can stimulate supplementary motor area. The intensity was 2 milliampere. The duration was between 15 to 20 minutes, and the most of the study use multiple session approach. When we use multiple session approach, we have a temporal summation of effect, and we can have a more significant effect in our patients. It is suggested to use TDCS in combination with other interventions like a therapeutic exercise, the most important intervention in neurological disease such as Parkinson. Another point is the state of medication. As we know, the patients with Parkinson have to eat some levodopa medications, and about 1 hour after eating the medication, they are in on state of medication. The on state of medications means that the function, the motor function, the cognitive function of the patient is improved, and we can have better neuroplasticity process in on state of medication. So it is suggested that all rehabilitation techniques like therapeutic exercise like TDCS applied during the on state of medication. And the maximum follow-up in the included studies was about 3 months, and the And effect of treatment was take 2-3 months. Another target area was a prefrontal area. We know that prefrontal area is an area in the brain that is its role is cognitive function. It's help us in decision making. It help us to improve our cognitive function, especially when we are doing dual task motor functions. I mean, when I have to walk, I have to also thinking about the day, thinking about my decisions, thinking about the problems. And it is better to improve the motor tasks under dual task condition, because it is more, it is better for our life. We want to prepare our patients to have a action role in the society, and in the society and in the real life most of activity are under dual task condition. 8 studies targeted the TDCS on DLPFC prefrontal cortex. In the EEG 1020 system, the DLPFC is on F3 or F4. The intensity was also 2 milliampere. The duration was 20 minutes. And also it was a multiple session approach. Uh, but despite the primary motor cortex, most of studies on DLPFC use TDCS as an standalone treatment, because they want to focus on cognitive function, not motor function, but the outcome was a motor function. I mean, the intervention was about cognitive function, but the outcome was gait function. So it was not necessary to apply cognitive training in addition to motor training. But now it is, we think that it is better to combine cognitive function with motor training function. As I told you, it is necessary to have the ability to improve the ability of our patients to do the task under dual task condition. Like motor cortex, the TDCS was applied on a state of medication, and the maximum follow-up in these studies was 5 weeks. Another part of studies were addressed freezing of gait. They have different approaches like unilateral M1 stimulation, unilateral DLPFC stimulation, or dual site stimulation targeting M1 and DLPFC simultaneously. The intensity was between 1 milliamp to 2 milliamp. The duration was 20 minutes. The TDCS was used as an standalone intervention, and the reports about the state of medication were not clear, and the maximum follow-up duration in these studies was 4 weeks. In general, it seems that motor area and prefrontal area are promising area for TDCS to improve gait in patients with Parkinson's disease. However, the result about the prefrontal area was heterogeneous, and there are also less explored areas for Parkinson and for gait problem in Parkinson. So we can now suggest a motor area. I mean 1 to 2 centimeters anterior to vertex for TDCS applied. The suggested intensity is 2 milliamp. There are a range of intensity for using TDCS between 1 milliampere to 3 or 4 milliampere, but most of the studies and most of the approaches suggested 2 milliampere intensity for TDCS. Some studies suggested using TDCS in combination with other other treatment approach. One study focused in comparison these two approaches. I mean, using TDCS as a standalone intervention and using TDCS in combination with physical training. And this study reported that combined treatment is better than isolated treatment. Another question is about using TDCS is applying it as an online approach or as an offline approach. In online approach, we use TDCS simultaneously with other training like gait training, but in offline stimulation, we applied TDCS before the motor training. It seems that both online and offline TDCS resulted in positive effects, but it is a question to optimize the protocol of TDCS, and we are not sure that which approach is now better for stimulation. And about the state of medication, as I told you, it is suggested to apply all rehabilitation approaches and also the examination of the patients with Parkinson's disease in the on state of medication, because the hypodopaminergic state has a negative effect in plasticity in patients with Parkinson's disease. As a take-home message, it seems that anodal TDCS is a promising approach for improving gait in patients with Parkinson's disease. It is better to apply it 1 to 2 centimeters anterior to vertex. The intensity of 2 milliampere and the duration of 20 minutes is a suggested protocol for TDCS. We have to use a TDCS in the on state of medication, and it is better to use it in combination with a gait training. And in the last slide, you can see the dome of Sheikh Lutfullah Mosque in Isfahan, Nakhshajan Square is Isfahan, and this is the cover of Cell Reports journal because of its dendrite shape. Thanks a lot for having me and listening to my presentation, and I am ready to answer your questions.